moving on to a workup, can you tell us a little bit about sort of next steps when you consider imaging or, other testing?
Yeah, so I'll get a CBC with differential, mostly looking for peripheral eosinophil counts to see if they have a systemic eosinophilia. For a while, I was using peripheral eosinophil counts to sort of guide my steroid treatment. Don't really use that as much these days, but it is a data point that helps us confirm a little bit about what's going on. I'll check a total IgE level as well. Again, a high IgE levels are associated with allergic fungal sinusitis. And then I also will check a RAST inhalant panel, mostly looking for evidence of type 1 hypersensitivity against fungal aeroallergens. Not so much concerned about the standard aeroallergens in this patient population, but it's part of the panel and it's sort of baked into it. But that's not really going to help us much for these patients.
So you send them to the lab for that.
Yeah, so it's just a blood draw. We try to get it the same day before we
Oh,
start
nice.
treatment. Yeah, so just they drop down the Quest and or whatever labs in the
Right.
building and get that done.
Do they need imaging right off the bat? Do you get a CT scan the first time?
Typically, it depends if they've been treated or not. If they've been quote unquote maximally treated, we'll just jump to a scan and get that done. If they've not been treated, we'll start some type of treatment and then bring them back typically in a month with a scan. I think they all need a scan, even if they get even a polyp patient has a good response to the initial medical treatment needs a scan because you need to know if there's a mucocele, if there's a high load of eosinophilic debris. Those patients are set up for failures and complications. I mean, I've treated patients who've had, vision loss from allergic fungal sinusitis, and it's because it wasn't picked up soon enough. And you can't tell just by looking in their nose with a scope. You're looking at the tip of the iceberg. You have no idea what's going on in depth.
Got it. So everybody gets a scan eventually.
Yeah,
And
they all do.
yeah.
We run a high resolution scan that's good for navigation on everybody, one protocol. I try to work with the same imaging center as well consistently. We have a printed out sheet. Whenever we go someplace else, half the time they do it incorrectly, even if we give them printed instructions. And I tell that to patients point blank. And even if it's a pain for them to come back to get our scan done at the regular place, most of them will come back for it
Yeah, so that they don't have to end up getting
too.
ultimately having to
Yeah.
redo it because it was
Rescan.
done
That's the
wrong.
worst.
Right.
Yeah, that's
Yeah.
the worst.
And when you with as far as your treatment for patients who are treatment naive, is there a particular, go-to treatment? Like, do you like to do oral steroids from the get-go or just budesonide irrigations, or how do you decide how aggressive to be with your
If they
steroids?
have, significant polyp burden on one side or both sides, I will give them a round of oral prednisone unless there is a strong contraindication. Depending on the polyp burden, it could just be a 12-day course of prednisone, starting at 40 milligrams and then dropping by 10 milligrams every 3 days. I'll pair that with antibiotics. I don't think the antibiotics do very much in many patients. But if you're thinking about there's a possibility of surgery, that's one of the check boxes you got to hit, right? So we'll do that. And then typically we add on a topical steroid as well, particularly as the prednisone is coming down, because the prednisone will open things up and then allow budesonide irrigations or exhalational delivery of fluticasone to get in. And so I'll prescribe that to start, and then they'll come back, typically within a month, maybe 6 weeks with that scan, and we kind of see how they're doing at that point.
And what, antibiotic how long are they on it for? Like 30 days, 2 weeks? And what do you use usually?
3 weeks is typical. I mean, I think it's arbitrary, but I say 3 weeks. And then what's interesting is with that regimen, most of the patients will feel better, right? It's just a question then of how sustainable the improvement is when the prednisone is off. The other thing, but I think what you get in some patients, when the prednisone opens things up and the topical steroid can get in, they continue to improve beyond those first few weeks, right? Because the steroid only hits the surface. The inflammation improves, it opens up a little more. Then there's more surface for the steroid to hit. So they can improve actually for weeks, maybe even months after initiating the topical steroid, after the sinuses have been opened by the round of the prednisone.
And which antibiotic do you like to use?
Amoxicillin clavulanate usually, occasionally doxycycline if they're allergic, or they've been on amoxiclav recently. Quinolones are an option too. As far as antibiotics, I will get a sample and typically send it for NGS sequencing as well. And if to identify specific targets, I think it just makes a little bit more sense if you can do that.
Do you wait for that to come back before you start anything? Or you kinda
Dep
do it
Depends on the
in
quality of the sample. If it's a good sample and then I will wait. It takes a few days. It's much more precise. Patients are accepting of that. You can explain to them that you're making a scientific choice about antibiotic selection based on the presence of bacteria. I am careful though when I talk to patients to not call it a bacterial infection because probably not. And that's a whole kind of rabbit hole that we can get into. But it's a factor that we can modulate with treatment with antibiotics, which probably drives the inflammation in some way.